Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice. Hello, this is James, and welcome to the podcast. And this week, I'm delighted to get the chance to chat with Dr. Giovanni Fava. Dr. Fava is a psychiatrist and professor of clinical psychology at the University of Bologna in Italy. He is also a clinical professor of psychiatry at the University of Buffalo School of Medicine and Biomedical Sciences. Since 1992, he has been the editor-in-chief of the peer-reviewed medical journal Psychotherapy and Psychosomatics. Giovanni has authored more than 500 scientific papers and is known for researching the adverse effects of antidepressant drugs. In a 1994 editorial, he argued that many of his fellow psychiatrists were too hesitant to question whether a given psychiatric treatment was more harmful than it was helpful. Dr. Fava recently released his latest book entitled Discontinuing Antidepressant Medications, published by Oxford University Press. The book is designed to be a guide for clinicians who want to help patients withdraw from antidepressants. I was keen to ask Dr. Fava about the book and to explore some of the concepts, including novel psychotherapeutic approaches to antidepressant withdrawal. Dr. Fava, thank you so much for joining me on the podcast today. To begin with, could I ask you to tell us a little bit about your background and how it was in particular you became interested in issues around the difficulties that some people have when they want to stop antidepressant drugs?
Yes. Unlike most of the researchers today, I actually evaluate and personally treat quite a number of patients, and I've always been doing that. And I think this is very, very important to get a good understanding of what's going on. So in the early 90s, in my practice, I started seeing patients having problems discontinuing antidepressant drugs. And I must say that I had a very extensive experience in discontinuing antidepressants with some studies we did, but these were tricyclics. The first generation antidepressants. So I was having these problems, and I saw that the literature was not really addressing these issues. Back in 94, I wrote an editorial in the journal I edited, Psychotherapy and Psychosomatics, raising some questions about tolerance issues in antidepressant drugs. And I must say that the freedom I enjoy as an editor was very valuable because it sparked quite a debate in terms of antidepressants. So the journal became a forum for hosting papers dealing with withdrawal syndromes after antidepressants or during tapering. I kept on seeing and assessing patients, and I noticed at a certain point, that was about a decade ago, that unlike some patients associations and other organizations such as yours, the thing was going to be to pass unnoticed. I mean, there were fewer and fewer papers. So we decided to do two systematic reviews on SSRI and SNRI. These were the first reviews. And Michael Hengartners in an editorial in another journal commented that these reviews came after nearly 200 systematic reviews on the benefits of antidepressant drugs. So 2 against 200. That is the ratio we are actually addressing. And this had a profound impact because from that time on, the term withdrawal has become more and more accepted. and use in the literature. So my knowledge comes from being a researcher and being a clinician.
Before we come on to talk about the book, I think you're perhaps quite unique in having a really, really good grounding and basis in psychopharmacology, but also having an understanding of how psychotherapy might sit alongside that. So I'm sure we'll come along to talk about that, but that kind of struck me as quite important in this work.
Yes, there are very few people around who have a research background and clinical background in both areas. That was quite common, let's say, in the old days, but nowadays, I'll say very, very few people.
I'd like to move on to talk about the book now, if that's okay. And the book's entitled Discontinuing Antidepressant Medications, and it's published by Oxford University Press. And I'm so glad to see this book is due to be released because, as you said yourself, there's a dearth of good quality material. In the book, you, as you just mentioned, you identify that in the 90s, the pharmaceutical industry planned to extend the use of SSRI and SNRI drugs beyond depression, and they took steps to popularize the term discontinuation as opposed to withdrawal. And so, yet here we are, we're 3 decades later, we still have the chemical imbalance being talked of. We still have doctors reducing drug dosages by, say, 50% over 2 weeks or very quickly, and saying that SSRIs are not drugs of dependence. So I just wondered what your thoughts were on how this kind of mythology about antidepressants not being drugs of dependence, how has that persisted for so long?
Well, it's not surprising. You see, in the 90s, the pharmaceutical companies were planning to extend the use of antidepressants to anxiety disorders, which in most of the cases is an unfortunate practice, as I write in the book. For doing this, they had to sweep away any reference to dependence, tolerance problems. And the basic assumption was the fact that, okay, you shouldn't be too abrupt, too quick in discontinuing antidepressants, but if you go on slowly, no problem is going to arise. Of course, any practicing clinician knew that this was not true, that you could have patients with a minimal decrease in dosage presenting the symptoms. The problem, you see, and you capture a very complicated issue at the beginning of the interview, is that not all patients develop withdrawal symptoms. And this creates some misunderstanding. But the big pharma, and this is a very sad story in academic psychiatry and psychopharmacology, most of the researchers obey to the sort of switch into discontinuation syndrome. As I said before, until 2015, when Gishwiner, one of the most important psychopharmacologists today, and our group came out with the idea discontinuation problems are no longer acceptable in terms of terminology. We should speak of withdrawal as we speak of withdrawal with benzodiazepines, with antipsychotics, and with any other psychotropic drug. So let's say that this is going on in terms of research and the journals, but in the meanwhile, the spectacular achievements of propaganda stay. No one has been knocking on the door of the primary care physician saying, okay, look, our view of these issues has changed. And so most of the clinicians are simply unaware of what has been going on in recent years. And this is why I wrote this book. I mean, to say, okay, we try to write something which may help the clinician in a way. And even though it's a very, very technical book, as, as you might have seen, also patience for giving perspective.
The book absolutely clearly delineates the, I think, the kind of clinician or patient-centered view of how difficult withdrawal might be compared to perhaps the more sanitized version that you read in academic journals, which typically says it's 2 weeks, it's mild, it's transient, and if it persists longer than that, it's almost certainly relapse, not withdrawal. So I think the book does a fantastic job of splitting apart the mythology and looking at the reality.
Yes, your point. Thank you for raising this. Is very bad. Not only that these are discontinuation syndromes, this means that you're going too fast and you have to slow down. But if there is withdrawal, you should think of a relapse and continue the medication again. By a commercial viewpoint, this is perfect. This means that you can have these people taking antidepressant drugs forever.
Yeah, absolutely. It's a market which kind of populates itself almost, doesn't it?
Yeah.
So in the book, I was also interested, you talk about the behavioral toxicity of psychotropic drugs, and I wondered if you could help me understand this concept.
This is a very important concept. And we owe this concept to two psychopharmacologists, the Boston area, Alberto Di Mascio and Dick Shader. And these were leading psychopharmacologists. I mean, Dick Shader still is a leading psychopharmacologist who were publishing their papers in the most important journals. And they elaborated this concept, which they were able to publish only in a journal called Connecticut Medicine. If you have people who regularly publish in the New England Journal of Medicine, and then you find this paper in Connecticut Medicine, I mean, a journal which is very hard to find, that means that that paper is very, very hot. And may undermine a lot of ground of the pharmaceutical industry. I'm simply applying their concept to the field of antidepressant tapering and discontinuation. A medication that is used at normal average doses may become toxic to the patient. And this toxicity expresses itself with phenomena such as loss of clinical effect. You have a patient who's doing well on antidepressant, and after a while, is taking the medication regularly, the antidepressant no longer works. If you try to increase the dosage, it may help for a little while. So loss of clinical effect, hypomanic episodes, that is, the medication is really working too much and brings the patient to a state of hypomania, or mania is what is in the DSM term of bipolar 2 disorder, but also paradoxical effect. That is, the antidepressant makes you more depressed. In the book, I discuss about the relationship between venlafaxine and apathy. This is an example of a paradoxical effect. And resistance, the fact that these patients become resistant either to the same medication when it's prescribed again or to other medication. Withdrawal is part of behavioral toxicity. And see, my view is quite different from that of other investigators in the field. Because as a clinician, I know that all these manifestations of behavioral toxicity are related. What I mean is that it's likely that you have 2 or 3 or even 4 of these manifestations together. And this means that there is the same mechanism.
That's really helpful. And it's hugely important, that concept, isn't it? Because if you're a patient at the moment, say, and you go to your doctor and you say, I've tried this antidepressant and it was working for a time, but then it didn't stop to work, you might get a label of treatment resistant, in that the doctor might blame you as the patient for you not responding to treatment, where actually what this might well be is a physical drug effect caused by taking the drug itself. So you can't really blame the patient if they haven't responded. It's an effect of the drug, isn't it? Not an effect of the patient's response to treatment. Is that right?
Right. You see, it's because in today's medicine, we have banned any iatrogenic thinking. I mean, we have been very well educated by big pharma. So there is this idea that the patient has to be blamed because he's not taking the medication regularly. And really, it's a very deceptive way of looking at things because there is one blind part and the iatrogenic part is totally blind. If you look at the psychiatric literature for papers that discuss about iatrogenic disorders, probably 1-2%. That is the current trend. So if no one has trained you to look at these issues, it's quite hard to have a balanced view of the clinical problems.
If it's okay, Giovanni, I'd like to move on to kind of the part of the book that talks about responding to antidepressant withdrawal. And I have to say it's a mine of really, really helpful information. And certainly really, really quite comprehensive in how it talks about responding to some of the difficulties that people have. So, what can we say, if anything, about the rate of tapering that might be helpful for people thinking about coming off antidepressants, because there's such disparity in the advice given out there. So professionals might choose to taper by a 50% reduction every 2 weeks, but online advice might be, say, a 10% reduction per month, which is quite slow and can generate extremely long tapers. So I just wondered, your clinical experience clearly informed your writing in the book. So I wondered what approach you typically adopt when you're helping people.
The first thing is that psychiatrists neglect something that is common practice in other fields of medicine, diabetology, cardiology, endocrinology, which is shared decision. Psychiatrists have a totally obsolete paternalistic approach. Let me decide what is good for you. But it's a situation where you have to confront the patient with different possibilities. So I practice a shared decision. So the first point is to have the idea that there is no simple solution that applies to all patients. I've criticized evidence-based medicine, and in this approach, it applies to the average patient. Unfortunately, I never see the average patient in my practice.
They only seem to exist in studies, don't they? Never in the real world.
And no average patient. I see the most difficult cases and so on. So the point is this: when I have to discuss with the patient what to do, I explain. First of all, we have to embrace a wider approach in terms of behavioral toxicity. Because the longer you keep the patient on a medication, the higher the toxicity you provoke. So I say, okay, the antidepressant, which was maybe very good at the beginning, has become sort of toxic to you, and it's creating this problem and so on. How are we going to proceed? So we can do very slowly if you wish, but be aware. By doing this, we prolong your exposure to the antidepressant. Or we can do it in a gradual but faster way. And here comes my position, and I realize that is primarily based on my practice and my experience, which is biased clinical experience, no matter how extensive it is. It's probably one of the most extensive in the world, but it's biased. So my bias, which I didn't have at the beginning, is that it's very difficult to discontinue an antidepressant, to do deep prescribing if you don't do some additional prescribing, if you don't use some medications and psychotherapy. So when I discuss with the patient about this, I'll say that most of the patient, 90% of the patient respond, please get this medication out of my body as soon as you can. And then we continue with that. But a basic problem, which is not only in this field, but is psychiatry and in medicine today, is to believe there is a procedure which should apply to all patients. Clinical practice shows that it's not possible.
We live in a society that runs on guidelines, don't we? Everybody wants a guideline, and yet this is not a guideline-focused activity. It's a person-centered activity, isn't it?
Right. And then behind a patient, there is a personal history, a treatment history, a unique combinations of medication. If I have a patient who's been treated, I'm thinking of the worst antidepressants, paroxetine and venlafaxine, and maybe he's also taking triazolam for sleeping. Here is different from another patient who's not been taking these medications, or it's very personalized. Let's not forget that personalized medicine is not simply genetics, but is really getting into the person's personal history.
Thank you, Giovanni. And again, I was interested to read, in the book, you caution against reinstating an antidepressant if withdrawal symptoms have already occurred. So I just wondered, what your experience was, why that might exacerbate the problems the person's having.
This was a suggestion that was made in guidelines and became quite popular. I mean, if the patient is experiencing withdrawal, go back to the same medication. Of course, this does not solve anything and may worsen the state of behavioral toxicity. But again, they want you to be very narrow-minded and just thinking of certain symptoms and not the general course of the disorder. So this idea, go back to the same medication, not necessarily it will work again if you have discontinued the medication or switch to fluoxetine. These are not based on research evidence. These were simply claims that were made, and key opinion leaders supported these claims and became popular. But there is no evidence whatsoever to support these strategies.
I guess reinstatement might, at best, dampen down some symptoms, but it still leaves that person with the challenge of getting off at some further point in the future, doesn't it?
Yeah, and it will certainly be worse because you have prolonged the exposure to the medication. This is a basic principle of toxicology. This is a strategy which leads you to nowhere.
And next, I think as we mentioned before, the book is one of the few I've read that gives kind of equal importance to psychopharmacology and to psychotherapy. And it would be perhaps nice to talk about some of your approach to psychotherapy when you're helping people with dealing with antidepressant withdrawal and discontinuation. So in the later sections of the book, you talk about 3 elements of psychological therapy that you employ as part of your staging process. So there's explanatory therapy, CBT or cognitive behavioral therapy, and well-being therapy. So perhaps it would be nice if we could touch briefly on each part. So firstly, you write about the importance of explanatory therapy at the start of the process of withdrawal. So could you tell us about explanatory therapy, what it is, and why it's important as the first step in the process that you follow?
Yes, explanatory therapy is a term and an approach which was introduced by a teacher of mine, Robert Kellner, for treating hypochondriasis and bodily preoccupations. And this was introduced many years ago. And I adapted this approach to the process of tapering and discontinuation of antidepressant drugs, in the sense that it's extremely important for a patient to understand what is going on. And in the book, in the first chapter, I described the first patient who had quite an acute withdrawal reaction, and he asked me, "What's going on here?" And then I kept on asking myself, "What's going on here?" Because in those days, we're talking in the mid-90s, there was no literature, nothing, and so we were really wandering in the darkness. So explanatory therapy means that you have to explain to the patient what's going on, why you're doing certain things, why you're adding, for instance, a medication. In the book, I've tried to put some clinical histories and cases, and also mention something that quite a lot of patients use. It's like being in a tunnel. I mean, it's total darkness. You don't know what's going on. You don't see any way out. You don't understand how you got in. And so you need someone who can see you out of the tunnel and tell you, okay, we are here, we're trying to go to another place and do these things. So to have some sort of direction. So this is explanatory therapy. Cognitive behavioral therapy is, of course, very common, but something that a lot of people forget is the fact that the psychotherapy is the most biological form of treatment that is available. And this is not a statement of mine. Harry Kandel, Nobel Prize of Medicine for Neuroscience, wrote a review on the biological effects of psychotherapy. I'm not questioning at any rate the importance of antidepressant drugs that I use in practice, but their effect vanish when you stop them. Whereas the tendency of psychotherapy is for the effects to persist. Let me give you an example. Someone, early 20s, anxiety disorder, agoraphobia with panic attacks, was given an SSRI. And the SSRI worked. Panic got better, avoidance improved. What was the problem? Again, not in every patient, is that when this young person wanted to discontinue and to get rid of this medication, and there are many examples in my book about this, they simply couldn't do it. It was a nightmare. Let's assume that this young person is among the lucky people who don't have withdrawal symptoms. By the way, this is really a total neglect, the waste of current research in psychiatry, not addressing the biological aspects of withdrawal, and not giving us a clue why certain patients develop symptoms and others don't. So let's assume that this young patient is not having problem in no withdrawal with tapering and discontinuation. But 90% of cases, according to the literature, when you discontinue the medication, anxiety, agoraphobia, panic will come back again. So what you have to do is not simply deprescribing, which is a term that I hate, really, because it's so narrow-minded, but you have to perform an alternative prescribing. In this case, you have to treat with cognitive behavioral methods those anxiety disorders that were present at the beginning. If you don't do it, the patient is going at the best to relapse, and at worst to relapse, having withdrawal symptoms with the course which has deteriorated over the years. So we need to prescribe psychotherapeutic approaches that deal with the basic symptoms. The third component is called well-being therapy, and this is a strategy that I developed over the years for increasing psychological well-being. In the book, I mentioned the case of a colleague. I wanted to discontinue antidepressant because it was not necessary at all, and she objected, I'm a weak person. I cannot survive without antidepressant. This is again another spectacular achievement of propaganda over these years. But there are a lot of people, physicians and their patients who believe that because they are inadequate, weak person, they could never make it without. So you need also some strategies, again, in an individualized process to address those aspects and to bring the strong points that any of us has inside to flourishing. So it's not deprescribing, it's alternative prescribing through psychotherapy in this case.
Yeah, thank you, Giovanni. I really like the focus on psychotherapy in the book because, I know myself from personal experience that coming off antidepressants can be a physically turbulent time, but it can also be an emotionally very turbulent time as well. So if you take someone's antidepressant away without giving them, as you say, a support mechanism via another route, and you tackle these issues as they're coming up, then, I think that's quite a difficult place for a person to be. So I really like the focus on psychotherapy.
I mentioned one of my teachers, Robert Kellner, but I should mention another of my teacher. As a medical student, I had the privilege of working in the summer with George Engel in Rochester, New York. And I remember Engel pointing to me one thing. It was about a patient we saw in a ward and said, Giovanni, remember, there is no difference between this orthopedic patient and the psychiatric patient. That was the biopsychosocial model in practice. They are both reacting with their body, their soul, their mind to certain situation. And of course, this is what I carried along. And this is why I've been trying to pursue both psychopharmacology and psychotherapy, because I'm an Engel student.
In addition to psychotherapy, which we've talked about, you talk also of utilizing clonazepam, a benzodiazepine, to help mitigate withdrawal symptoms. So I wonder what your observation was of using a benzodiazepine in this way, and do you taper that once the SSRI withdrawal symptoms have eased or reduced themselves?
Thank you for addressing this issue. In my practice, at a certain point, I became convinced that it's tremendously difficult to get rid of antidepressants without any other form of pharmacological support. And of course, if you switch to another antidepressant that, so in terms of behavioral toxicity, you're going nowhere. You're making no progress. And I've been, as I write in the book, very much influenced by one of the most important psychopharmacologists, Guy Chouinard, and we discuss many times these issues. He suggested to me that we needed to associate with the tapering and discontinuation for some time an anti-epileptic drug. And I chose clonazepam for various reasons. I mean, the first, because it has very good anti-anxiety properties. Chouinard did the first study on alprazolam, but then he went on and he sort of concluded that this medication was giving a lot of dependence, was not good, and then introduced clonazepam as an alternative. Also because I have to deal with a lot of patients with anxiety disorders, I think that clonazepam may help both decreasing, not eliminating, the symptomatology, the withdrawal symptomatology, that is new symptoms that appear, and the other is that of decreasing anxiety symptoms that may appear. So when we talk about benzodiazepines, we make another common mistake. We talk about a class, a medication class, as if they were all the same. They are not. And we have clear-cut evidence that there are benzodiazepines, such as I mentioned alprazolam, I could mention triazolam, I could mention lorazepam, have very strong addictive properties. And there are benzodiazepines that have very low dependence liability. And clonazepam, and again, there is evidence about it, is one of those. In my personal experience, again, we're talking about hundreds of cases treated with clonazepam, of course, with gradual tapering at the beginning, but I never had problems. So one should be very cautious about benzodiazepines altogether, antidepressants altogether. So we're talking about different medication that belong to the same class.
For people out there listening who haven't had access to the literature, you know, that there are many messages out there to try and make sense of. On the one hand, we're often told in simple terms that SSRIs, SNRI drugs are safe and effective and can be taken indefinitely or for long periods with no problems. On the other hand, when in-depth investigation is done, such as that in your book, the problems with the drugs are manifest and can be very serious for some. Everything up to manic episodes, akathisia, increased risk of suicidal thinking. So how can we as consumers kind of reconcile these two views of psychotropics?
For a consumer, it's not easy. It's not easy. But let me point to a sort of similarity, and let me take the example of antibiotics. Okay. Of course, antibiotics are life-saving medications, and one of the most important achievements of medicine. but they should be taken when there are precise indications and generally not extended over a week or 10 days. You see, the conclusion of my book is really is really something that go against all current indication, is that antidepressant drugs are life-saving and important medication if you meet certain criteria for severity and persistence of depression. So limited to the most severe cases for the shortest possible time, which in case of antidepressant drugs is no less than 6 months altogether, if in realistic terms. And when you taper the medication, you have to introduce something else. Another position that I take, again, not a very popular position, they should not be used in anxiety disorders. Unless, of course, the only time where I may use them is when you have anxiety associated with severe depressive disorder. But if I have to use a medication in anxiety disorder, I use benzodiazepines. They are far better, not all of them, as we discussed. So it's something that we should acknowledge about all medications. In my journal, a few years ago, we published a review on long-term side effects of SSRI and SNRI, and it's just a devastating list. These are medications that are not good for long term.
That kind of goes back to something you mentioned earlier, which is, that the way that these drugs are sold, if you like, in terms of how they should be used. So if people believe that they've got a chemical imbalance or a broken brain, or they're missing something that the antidepressants provide, then that kind of signals that they need them long term, doesn't it? But if we sell them or give them as if this is a temporary solution to help you over a particularly difficult or problematic time in your life, and they might help you over that with some psychotherapy alongside it, but they're not adding anything that you're deficient in or correcting any brain or abnormality. Those two conceptions are quite different, aren't they?
Yes, you're doing explanatory therapy right now. Okay. Yes, this is what we need to exchange. Let me add this, that this book actually reflects a lot of things that I learned from patients. I mean, their insights, because as George Engel was teaching us, medicine is about interaction. It's not about technology only. Is the patient and the physician are part of the same process, and this is what I try to do in the book, and to see that okay, I may see things better than the person who is in the tunnel, but at the same time, I also have a lot of blind spots. I also have a lot of uncertainties. Things may go one way or the other way. The important thing is to transmit the idea that I've got the experience, I got the knowledge to address different things that may happen during the course of illness.
Thank you. You've clearly put a great deal of time and effort with colleagues into the research that underpins the book. So what are your hopes now for how the book will be received, or how it might end up being used by people who go on to prescribe SSRIs and maybe go on to help people withdraw?
Someone asked me recently, it was of course a joke, do you think that pharmaceutical companies are going to support this book? And say, well, they might buy all copies to make it disappear. So I'm aware that when it's going to be released at the end of the month, I have a lot of people against me. not only those who are linked to pharmaceutical companies, but the book expresses some views that are not shared by a lot of colleagues. When in '94 I wrote the editorial, do antidepressants and anti-anxiety medication increase chronicity in mood or anxiety disorders? That was in '94. Of course, I knew I was going to have a lot of problems. When in the journal we published the first David Healy's paper on suicidal ideation and antidepressant, that analysis, I knew I was going to have a lot of problems. And when we published the review on the systematic review on SSRI and the editorial by Shrinath on criteria, we thought, well, let's see what happens. And we did not expect that we were going to hit the literature to a point that the term discontinuation syndrome is almost no longer used. So what I hope is the book, and more than the book, the ideas, the experiences, the messages, what the patients tell through me in the book may get a widespread distribution. And people start thinking about a lot of issues. I'd like to mention something funny. I was told that a physician who has a very high position in a pharmaceutical industry, and certainly an absolutely brilliant pharmacologist, something he said about me. He said, okay, if Giovanni Fava spoke about psychotherapy, I'll be the first to come to listen to him. I mean, insights, the way his self-therapy is absolutely fascinating. The problem is that he discusses also about psychopharmacology, and in a few minutes, it can induce irreversible damages. And what are these irreversible damages? People start thinking. People start using their clinical judgment. People start wondering what's going on here. Is the way we're treating patients the right way? Or maybe there's something else we can do. My academic colleagues will ignore this book. I already know that, because it would be embarrassing for them. I hope that organizations like Med in America or Surviving Antidepressants or other, they may have spreading the word. But I'm optimistic because I saw that 2 articles in a small journal were able to induce a lot of changes. Of course, here we are talking about a different psychiatry, a different psychiatric model. So not something very simple.
I was going to ask you about that, Giovanni. So the book does call for a revolution in our way of thinking, assessing and treating mood and anxiety disorders, and you call for a different psychiatry. Do you think that's actually possible without us somehow fundamentally rethinking the relationship between psychiatry as a profession and the pharmaceutical manufacturers?
I call revolution because it actually needs some drastic changes in our way of looking at things. We need a different type of assessment. But the DSM, this diagnostic statistical manual that everyone uses, if we think about it, is for patients who no longer exist. Because the DSM is for patients who are drug-free. Okay, in my practice, 95% of the new patients I see are already taking psychotropic drugs. And these medications are changing the picture. The DSM does not consider this. So it's totally outdated. So it's a total different approach to the assessment of the patient and to its treatment. But of course, as any revolutionary approach, I know that I'm going to have a rough time in suggesting. But at the same time, it's really more and more people may start thinking and reasoning and so on. So let's say I'm reasonably optimistic that in the long run, don't ask me how long, certain of these ideas will come true. Let me close with something that impressed me so much, and it's also a message for the patients, for the people who have been left alone by official medicine and psychiatry. Because when you disregard major psychiatric medical symptomatology, you're really deserting all these people. So many times I've been asked this question: shall I be back to the way I was? My answer is very simple. I hope not. This would be a disaster. You never go back. I mean, this is the basic idea. And we owe it to one of the most brilliant neuroscientists, Bruce McEwen, at Rockefeller University, is known for his landmark studies on neurons, but he was also a big supporter of social neuroscience. And the point is that recovery is a one-way street. You never go back to the situation. It's not that because you taper very slowly, then you go back to the point where you were before taking the drug. That's no longer possible. You can only go forward. At the same time, taking, as one patient shared with me recently, it has been hell. But at the same time, I understood so many things. I've grown so much. I'm different, that I'm growing. So the message is that to go forward, to look at the future, but you need to build, you need to prescribe something different and not simply deprescribing. Okay, thank you for your questions, and I hope that the book will bring some helpful debate.
Giovanni, thank you. I'm so grateful to you and your colleagues for all the effort that went into the book. And, it is very detailed, it is very technical, but everything is described very clearly with very strong examples. And, in terms of how this book might be used by people like me, by consumers, it's possible to read your book and become confident enough to start to have discussions with your doctors that might allow you to challenge some of their thinking, but from a perspective of someone that's read some really, really good quality research. So that's where I see value for someone like me, that it equips me with the kind of language and the kind of examples and the kind of research that I need to go and say to a doctor, maybe an antidepressant isn't the right thing for me, maybe this would be a better approach for me, or maybe we should approach withdrawal this way. So I thank you so much for writing it and for all the effort that went into it.
Yeah, thank you for this interview at the space.
Well, I just want to thank Giovanni so much for taking the time to chat for the podcast. If you are interested in reading his new book, it can be purchased from Oxford University Press by visiting the website www.oup.com/academic and searching for Discontinuing Antidepressant Medications. Either that, or it is available from Amazon.com in print or for Kindle devices. So thank you so much for listening, and until next time, take care. Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.